Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds in Thoracic Surgery. Premier education brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. I'm Eric Lim, and this week it's a great delight for me to present Professor Martyn Caplin, who is one of the leading experts in neuroendocrine tumors and the lead for the ENETS Center of Excellence here in London, to give us an overview of what's the latest in neuroendocrine tumors. Martyn, over to you.
Thank you very much, Eric. A lot to get through, so I'll crack on. But it's a really great pleasure and honor to be part of this this morning. So thank you for the invite. So I'm going to cover bronchopulmonary neuroendocrine tumours, really concentrating on typical and atypical carcinoids. These are my disclosures. So there's been an increasing incidence of neuroendocrine tumours of all types over the last 20 years, probably because of the improvement in both diagnosis, pathological diagnosis, as well as endoscopic techniques, and that's whether it's bronchial at the top or small intestinal, rectal, and so on. For bronchopulmonary neuroendocrine tumours, many present as just incidental findings, but you may present with cough and hemoptysis and recurrent infections, etc. If we look at the very latest data actually just come out in the last month, looking between the years 2000 and 2020, the incidence of lung nets per 100,000 population has gone up from 0.85 to 2.5 per 100,000 population. And you'll see that it's more common in females in graph B, and middle age onwards are the predominant groups, with on the bottom graph typical carcinoids being by far the most common in incidence, and then the large cell, and at the bottom there, atypical carcinoids. You know, there have been various iterations of the WHO classification over the last 5-10 years. And for typical and atypical, which I'm concentrating on this morning, the question is it helpful? We've added in the Ki-67 proliferation index. My goodness, what politics there is to even get some recognition of Ki-67, which is the grading standard in gastroenteropancreatic neuroendocrine tumors. A lot of politics when it comes to lungs for some reason and including it, but it's said to be helpful in defining typical and atypical, large cell and small cell. We think it's a very important adjunct to the histological accuracy for the classification. And so this is the Ki-67 in typical, panel A, B, atypical, large cell and small cell neuroendocrine carcinoma. But can you really be talking about atypical, typical and atypical carcinoids these days? Because there is actually a blur between the groups, as well as you can see here in this genomic analysis study. And there's also a group of atypical carcinoids which act in a much more aggressive fashion, a bit more like the large cells, and so which are being called the supracarcinoids. And so now there's a discussion about, so you've got your typical bronchial carcinoid, atypical, and then you've got carcinoid with high mitotic proliferation index. This is the supracarcinoid group before you go on to the large cell, small cell. And that's based on the higher mitotic count, but also, in fact, again, where the proliferation index comes in the Ki-67 proliferation index. But these tend to be still well-differentiated types of neuroendocrine tumors. And unlike, for example, in small cell, there's no loss of its wild type RB1, and there's wild type P53 in that often in that supracarcinoid group. So there is still room for further discussion regarding the classification. In terms of overall survival, as you know, typical carcinoids last in terms of their overall survival. That you're talking about long-term survival here. You're seeing the 10-year graphs for typical, atypical, and large cell and small cell neuroendocrine carcinoma. No surprise in terms of the staging. I just want to mention, though, DIPNEC, diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. So here you're getting a proliferation of the peribronchiolar pulmonary neuroendocrine cells, often accompanied by nodules, which, if they're less than 5 millimeters in size, will be called tumorlets. If they're 5 millimeters or greater, then that's little carcinoid tumors, often accompanied by constrictive bronchiolitis caused by peribronchiolar fibrosis, probably related to a variety of peptides contributing to this. And so that you see classically on the chest X-ray and on the particularly on the CT imaging, the mosaic pattern, but also multiple nodules as well. And you can see on the left the little nodules which have been grown slightly over 8 years, where the white arrows are on the left. And you can see on the bottom panels, A and B, the sort of bronchiolar nodularity and thickening there as well, with the white arrows in panel B. So we looked at DIPNEC in over 300 patients who had resection for their carcinoid tumor, and 61 of it's said to be rare, but it undoubtedly isn't when you look for it. 60 of 300 had DIPNEC, and 95% were female. And predominantly patients had typical carcinoid and a small proportion atypical. Some had combined typical and atypical. What was interesting in following these patients long term, that those who went on to have metastasis, the small number, had, even though they had might have only presented with typical carcinoid, when one looked at the metastasis, it was atypical carcinoid. So the question then is transitioning from typical to atypical as well. There can be syndromes associated, often quite rarely carcinoid syndrome. If you've got liver metastasis, then that it may be up to 15% of those patients in bronchial metastatic neuroendocrine tumors, making serotonin and elevated 5-HIAA, but often having slightly atypical carcinoid due to histamines and tachykinins being released as well. Rarely you get ectopic ACTH, really rarely IGF-1, growth hormone releasing hormone as well. Not really associated with typical and atypical bronchial carcinoids in terms of inappropriate ADH. You'll know better than me in terms of small cell carcinomas, and rarely ectopic insulin. The biomarker that we tend to use is cremogranin A, not so helpful. It's quite non-specific as well. You want to exclude multiple endocrine neoplasia type 1 familial screening. Initially, that would be done just using calcium and PTH levels, but probably only affects less than 5% of all bronchial neuroendocrine tumors. In terms of the imaging, the gallium-68 dose-take PET has changed matters considerably. Certainly more sensitive than the octreotide scan that used to be done. The dose-take PET, when we looked at this is in over 1,000 patient scans, and across all neuroendocrine tumors, including lung neuroendocrine tumors, having the ability to do a dose-take PET affected management in over 40% of patients by making them amenable to putting them on somatostatin analogs, by diagnosing lesions that were thought not to be there, having an impact on surgery, and so on. FDG PET, entirely appropriate for high-grade neuroendocrine tumors, so the atypical large cell, small and small cell, less useful for typical, although if you've got a lesion and a negative FDG PET scan, you start thinking about typical bronchial carcinoid. What's really helpful in terms of the dose-take PET scan is, in fact, not only picking up the soft tissue lesions, but those bone lesions as well. And that actually, we've seen patients who've had reportedly normal CT scans. You do a dose-take PET and you find multiple bone metastasis, particularly in bronchial carcinoid patients. And as I say, more often it's in typical than atypical carcinoid patients. And the other is that you can get false positives. So here you can see the FDG PET on the top, gallium dotatate PET on the bottom. And the dotatate PET is lighting up as a hotspot the typical carcinoid tumor. The FDG PET is negative for the typical carcinoid, as we would expect, but lighting up the focus of infection there. So you have the false positive aspect of the FDG PET as well. Brain metastasis, actually not common in patients with typical carcinoid, can rarely occur, more commonly seen in atypical, and as you know, in small cell lung cancer and large cell. In terms of surgery, lots of different publications and other reviews. It's a 24 review I just highlighted, but actually hasn't really changed. And outcomes are better, obviously, for N0 rather than N1 and N2. But what you'll see here, again, over 10 years, survival in N1 disease for typical carcinoids, and to that matter, atypical carcinoids, is still very good. And then even for N2 disease in typical carcinoids as well over a 10-year period. What about endobronchial treatment? There is very, very little data in regard of this, whether that be for laser APC, cryotherapy, or PDT. What one can say is that patients must have a dotatate PET as part of the regimen, because you've got to be looking at the question of lymph node metastasis, and actually it should really only be for tumours of less than 15 millimeters in size with purely intraluminal growth, and Eric will comment on all the surgical issues that are raised when you get incomplete local ablation. Medical therapies, we'll just briefly cover the various medical options. In terms of the SPINET trial, this was really disappointing because the trial ended early due to slow recruitment, but got just about enough data for us to be able to get some answers of lanreotide, also the once monthly somatostatin analog versus placebo. And the median PFS for the lanreotide for the overall group was 16 months. In typical carcinoids, PFS, this is in patients with progressive disease, 22 months versus 14 months for atypical carcinoids. And if we look at that versus lanreotide versus placebo, it was 22 months versus 14 months in the placebo group for the typical carcinoid, showing how indolent the typical carcinoids can be. For atypical carcinoids, there was no real difference between lanreotide and placebo in terms of the PFS. So the role for somatostatin analogs is for the typical carcinoids, avid on dotatate PET. The atypical carcinoids avid on dotatate PET with just very low Ki-67 proliferation index could be considered. What about the mTOR inhibitors? Strong expression in terms of the bronchial carcinoid proliferation pathway. One has the RADIANT-4 study, which include intestinal as well as bronchial neuroendocrine tumors, 2-to-1 everolimus versus placebo. Clear benefit of everolimus over placebo in terms of PFS. And you can see in the different subgroups at the bottom that the lung carcinoid population had significant benefit with everolimus. And then specifically in the publication for Nicola Fazio, it showed that the PFS in the lung carcinoids on central review was 9.2 versus 3.6 months. On local review, 13.5 versus 3.5 months. And just come out as well as cabozantinib, now licensed in the States and also included in the NCCN guidelines that have just come out. Quite interesting, this broad TKI inhibitor. So it did include lung and thymus. I'm not covering thymus today. These were in quite heavily pre-treated patients. And it showed that in the extrapancreatic group, which included the bronchial carcinoids, there was a benefit over placebo, 8.5 versus 4 months. And you can see here in the subgroup analysis on the right, the benefit in the lung and thymus group, then hazard ratio 0.17 as well. So that was the reason why it's included now in the NCCN guidelines. Chemotherapy, temozolomide has been the chemotherapy of choice in patients with progressive disease, usually in the atypical group, which are acting progressing more rapidly. As a single agent, I think people are moving away from single agent temozolomide, and most people now use oral a combination temozolomide and capecitabine, talking about 30% partial response rate, but probably overall benefit in around about 80% of patients in terms of controlling disease, PFS somewhere between a year and 18 months usually. And if we look at the chemotherapy and the different types of neuroendocrine tumors, so you've got CAP10, as I say, between 9 and 18 months. Temozolomide monotherapy, not quite as good. Platinum etoposide, really just used for rapidly progressing atypical carcinoid or neuroendocrine carcinoma. Streptosin 5-FU, I think we're the only ones at the raw free using that these days. That has similar PFS to platinum etoposide regimens. We would use that in the more rapidly progressing atypical carcinoid and the large cells. FOLFOX is a second line after progression, and FOLFIRI third line. PRRT, so intuitively you light up the tumors as hotspots on the dotatate PET. With a gallium-68 dotatate PET, you can change the radioisotope for lutetium, so 177 beta emitter, and by that way specifically target the cells. You see rather dramatic responses. You can see on the panel below the liver metastasis pre and post therapy, and the results are good, really well tolerated. The objective response rate is somewhere between 15 and 25%, but the overall disease control rate in patients with progressive disease is 80%. And you can see really good median PFS of somewhere between 20 and 30 months as well. So this treatment, we're actually doing a prospective trial on the PRRT in metastatic bronchial carcinoid patients at the moment. Immunotherapies, disappointing for all neuroendocrine tumors, but may have a role in the high-grade neuroendocrine tumors. So if we look at CTLA-4 inhibitors such as ipilimumab, nivolumab, PD-1 inhibitors, one of the original trials was spartalizumab. You know, this is a patient with atypical carcinoid, showed good response after 4 months, but then relapsed by 8 months. And then there's limited role for single agent immunotherapy. Most people will be considering ipi-nivo combination, and you can see that actually some of the best responses are in the atypical carcinoid group in terms of seeing impact on in terms of partial response rate, and PFS as well. So limited to the more higher grade neuroendocrine tumors, particularly the bronchial ones, but we need to understand that more. It's been shown in a variety of studies as well. You can see the overall response rates for well differentiated versus the neuroendocrine carcinoma being high, but limited PFS overall. So in conclusion, we've got the ESMO guidelines showing that with typical carcinoids, you might actually, in metastatic disease, just observe, because it's so slowly growing, if there's signs of growth, move to somatostatin analog. For progression from typical carcinoid, then you can move across onto considering everolimus. If it's rapid progression, temozolomide. If they've got positive dotatate PET, which they should have, then consider PRRT. For atypical carcinoid, you might use somatostatin analogs if they've got very if they've got slowly progressive disease and positive scans. Everolimus, again, can be considered temozolomide for more rapidly progressive disease. PRRT, less commonly used for atypical carcinoid because often when they're being more aggressive, the gallium dose-to-take PET is negative, but if it's positive, can be considered. Otherwise, further chemotherapy. So in conclusion, we need better predictive and prognostic markers for patient choice of treatments and stratifying. Is it outdated to be talking about typical and atypical carcinoids? I think we need to be reassessing that. The role for dose-to-take PET I've discussed. We've discussed DIPNEC as well. The caution as well over local endobronchial therapies. Somatostatin analogs for typical carcinoid, molecular targeted agents, everolimus, cabozantinib looks interesting. PRRT, a good treatment. The role for CAPTEM as a chemotherapy agent. Immunotherapy still to be worked out. I think we have to work out the best combinations as well. The whole role of debulking surgery, oligometastatic disease. We're always sending off, we're resecting bone metastasis, and if there's just a single lesion. Patients need to be discussed in specialist MDTs and expert centers, and it's always good to have Eric on our calls as well when we're discussing in the joint MDT. That's the lot. So thank you very much for that brief run through of typical and atypical carcinoids.
Excellent. Thank you very much, Martyn. A fantastic presentation as always. Maybe I'm going to start with a few questions. You covered the entire spectrum, so that's really great. Taking it step by step, can I ask, from a staging point of view, given the advances and precision of gallium dotatate, do centers around the world still need to do FDG PET for staging of bronchopulmonary carcinoids?
Yes, in terms of often they'll end up doing it because they see a mass lesion and they don't know what it is, and the traditional pathway is the FDG PET. But certainly when it's negative, you think, oh, could this be carcinoid? Electively, if you know from biopsies what you're dealing with, then certainly in the high grade, so atypical and high grade neuroendocrine carcinomas, then yes, you would do an FDG PET. You could argue just for a typical carcinoid, you don't need to do it. You can do the just dose-to-take PET and assess with that with the CT imaging as well.
Excellent, thank you. And can I ask, for patients with bronchopulmonary carcinoids going to surgery, what's the risk for those who don't have the full formal endocrine screening to screen out for secretory tumors?
Yeah, so you want to, so from the anesthetist perspective, you want to have considered carcinoid syndrome. Because as I say, although it's unusual, it's not rare. So 2 to 5% with just those with localized primary tumors might have a carcinoid syndrome. And from the anesthetist perspective, it's important. It's easy to do a 24-hour urine 5-HIA. In fact, we're going to have the blood assay up in about a year's time within the year as well, which will make it even easier. And because of the carcinoid syndrome instability during surgery, you just want to have considered that. The other syndromes are really very rare, but also again, in terms of considering ectopic ACTH secretion and Cushing's, you just want to be aware because of the impact then on patient management long term, whether some patients need bilateral adrenalectomies as well. So you have to just be thinking a little bit about all of those things. And I guess that's where the multidisciplinary team helps as well, and making sure you've covered all of those thought patterns.
So in summary, for all known or suspected neuroendocrine tumors, do a formal endocrine screening before taking the patient to theater.
Yeah.
Got a great question from Dr. Borselia, who's asking, do the same guidelines for surgery apply to neuroendocrine tumors as it is for the garden variety non-small cell lung cancers?
You would know that better than me. Yeah. You can.
So, I mean, from my point of view, I would say no, the indications are quite different because, and also working with the Royal Free Neuroendocrine Tumor, what's interesting is lung cancer guidelines for non-small cell lung cancer are made on tumors with a different profile of aggressiveness. And I think that the profile which is most similar is the atypical carcinoids. But the typical carcinoids have a very different profile, and therefore certainly our work with the European Neuroendocrine Tumour Excellence Center with Martyn Caplin to offer surgery in more wider setting, including metastatic disease, with the attempt to achieve a complete resection if possible. So I think that answers quite a few questions from those
Yeah.
who have already
You've
posted.
operated, as you say, even patients with liver metastasis and with the impact of clearing disease. Even in recurrent disease, you've been in there and fished out lymph nodes again. And even the question of leaving R1 resection in someone who's got a very low grade, if you've managed to debulk and help symptomatically, leaving R1 in a typical carcinoid can still be an appropriate option because we've got all these other treatments available.
Dr. Patel from the Royal Free is asking about any information on the role of radiotherapy for the treatment, radiotherapy presumably on its own as opposed to PPRT.
Yeah, so
Carcinoids.
and it's part of our group. Good morning. We actually, it's always said to be somewhat radio resistant, and we tend not to use radiotherapy except for bony metastasis and what's for symptomatic bony metastasis. I suppose the areas thymic, actually for some reason thymic carcinoids, I haven't discussed it, do respond well to external beam radiotherapy, but less so the typical and atypical bronchial carcinoid. So it tends not to be in the algorithm, and except for symptom control. We're looking at a small number of patients with SBRT and trying to assess that in patients as well. So I think no for standard external beam radiotherapy, limited options for symptomatic control, usually different for thymic carcinoids, interesting in terms of SBRT.
Great question from Malcolm Wills asking about the management of DIPNEX. Given the low rate of growth, what is the timing of appropriateness of lung surgery? I think from my point of view, how do you identify whether or not one of the many nodules is starting to become a problem, becoming more malignant, or deviating from the usual DIPNEX low growth profile?
Yep. So it really is the screening of the CT every 6 to 12 months. As you know, you can on background of DIPNEC, it may be more typical to have typical carcinoids, but you can get atypical and you can get lung cancer. So you can't be given a total sense of security in terms of DIPNEC. So I think regular screening, our screening would normally be usually 6 monthly scans, but you may not see any changes over for many years, and so those patients may move to an annual review. And then in terms of, and then you might only just be treating the single lesion that's growing and leaving the other lung nodules as well. So you're just identifying that way. The other thing is, well, what do you do over in patients with DIPNEC might only have tumulets, but they're symptomatic, as you know, that can be a problem, and the coughing and somatostatin analogs tend not to make such a big impact. I think anecdotally, we use steroid inhalers. I think anecdotally, Montelukast, for whatever reason, has been useful in the past, and the old cipraheptadine antihistamine can be useful. So that tends to be our go-to trial in patients with persistent cough, which can be difficult.
Another great question from Dr. Obaid, who's asking, given the slow growth rate of typical carcinoids, if it's not, say, compromising the lumen of an airway or its peripheral located in the lung, what is the options for conservative measures, presumably no treatment at all?
Absolutely. And so we do have a significant proportion of patients where we'll just say, you know what, you're well, it's a very small lesion, and sometimes may not change for many years. We'll just keep you under surveillance, and that's entirely appropriate. For very slowly progressive disease, you might consider a somatostatin analog once a month injection, but may not need more than that. But I have a number of patients we don't do anything for.
Excellent. As always, Martyn, there's too many questions and not enough time for answers. I want to thank you once again for an amazing talk. And also to our sponsors, AstraZeneca, Medtronic, and Medillia Science of Care. Next week, there's no meeting, and we'll be back the week after talking about robotic lung transplantation. So, Martyn, thank you very much once again. And
It's been a great pleasure and good to see you. And thank you to everyone for joining.
Thank you. Bye-bye.
Bye-bye.